These slides were developed by Crystal Jordan, who many of you have seen previously at our different Lunch and Learns. And Crystal developed these slides. I'm presenting them for her because she couldn't be with us today. So we've talked about physiology of sleep already. We don't have to run through this too much in detail. But again, that non-REM sleep is 75% of our sleep. We need our REM sleep. It's 25% of our whole sleep. And our sleep cycle of the different stages of sleep, stages 1, 2, and 3, and then REM sleep that we talked about earlier slide, is that whole architecture. And a lot of different things can impact that architecture of our sleep. When we talk about insomnia, we touched on this on another slide, but we have sleep-related breathing disorders, which sleep apnea is part of. Hypersomnia, who knows what that is? Hypersomnia, too much sleep. And sleeping too much can give problems with sleep disorders as well. Circadian rhythm sleep disorders, not getting through the full REM sleep cycles. Sleep-related movement disorders, that restless leg syndrome that we were talking about. And then one of my favorites that we have in the big word too, parasomnias. Does anybody know what parasomnia is? Nightmares, night terrors. And we repeatedly have nightmares over and over again, and it starts to disrupt our sleep as well. So with insomnia, or having problems with that quality of sleep, or either falling asleep or frequent wakening, we know that 55 to 60% of people that suffer with insomnia are female. We also know, though, that as we age, we have that difficulty initiating sleep, having the amount of sleep occur, and the increased amount of wakenings. We also do have an increase in situational stress that can affect our sleep quality as well. So think about those times when you've been very stressed about an incident that happened in your life. It may be the death or the passing of a loved one. And think of how that disrupted your sleep quality at that point in time. And that's very, very valid. But then environmental, the noises around us, how dark the room is, how cool the room is. If we have poor sleep hygiene, doing too much computer work, having too much nicotine, caffeine, alcohol before bed can disrupt the sleep. If we have a comorbid mental health condition, so people that have untreated or worsening anxiety or depression have a change with their quality of sleep as well. And then different substances and medications. Medications can help with sleep, but medications can hurt your sleep as well, and we'll go through some of them. We also know that people that are unemployed or have a lower socioeconomic status, and I think it's more due to stressors, they have an increased percentage of insomnia as well. But these are some of the medications that can actually give insomnia. So people that are on stimulants like methylphenidate, this is one of the medications that we treat attention deficit disorder with. And adult survivors of ADD may be on the same medications that they were on when they were children, but it can disrupt your sleep. Anticonvulsants, these are anti-seizure medications, and many people will use anti-seizure medications for neurological or neuropathic pain as well. And sometimes this can actually give problems with insomnia. My wife, that I was talking to you about before, she's a sufferer of this. She had a few car accidents where she had whiplash and having chronic headaches after that, and her neurologist put her on an anticonvulsant or an anti-seizure medication. And while it was helpful for a decrease in the pain that she was having from the headaches, she noticed that she became a very light sleeper, where she wasn't a light sleeper before. And she's not getting into the very heavy sleeps that she was, and her neurologist said it was actually the medication that was the culprit. Corticosteroids. Well, what medication is that? Prednisone. If anybody has ever been coming to see me in urgent care and they're covered head to toe with poison oak, one of the treatments that we use is prednisone. And prednisone is a very potent anti-inflammatory. It works really, really well, but it can really mess up people's sleep in terms of making them feel overheated at nighttime, or making them feel like their mind is racing because of being on the prednisone, or people have described worsening nightmares or dreams or very vivid dreams. So we know that medications like prednisone, corticosteroids, can affect your sleep quality. Diuretics. What is a diuretic? It's a medication for blood pressure. What is this medication for blood pressure? How is it using, or how is it working? It works by decreasing excess water that you might have in your body and making sure that you pee it out. So what's one of the disruptors of good quality sleep? Well, getting up to go to the bathroom every few hours. So diuretics, while they're helpful with blood pressure, they can be harmful with your sleep. And then beta blockers. We use beta blockers a lot to control heart rate, to also control high blood pressure, and to control changes that the heart is going through if you have a condition called congestive heart failure. But beta blockers have been known to also disrupt your sleep and give poor quality sleep. Antidepressants. There's some class of antidepressants, the tricyclics, that can actually help you with sleep. But other classes of the antidepressants can, while they're treating your depression and making that better, starts to disrupt your sleep quality through your REM sleep cycles. And then nicotine, whether it's in a vaping, whether it's in a cigarette itself, but nicotine can disrupt your sleep as well. So what do we do in the first place if we start to have poor quality sleep with the diagnosis insomnia? First line over and over and over again should be non-pharmacological management. We shouldn't rush to a sleeping pill right away. And many people think that that's the strategy. But when we're talking about sleep hygiene, we have to do a personal inventory of what else is going on in our environment and what else we can do to make the environment conducive to good sleep, and to also understand what amount of poor sleep is just due to the aging process. So what is it that we can still sort of fix? So first line is always non-medication. But second line, if non-medication is not working, there's some medications that we can use, and then there's some third line medications that we'll get to, and I'll show you the difference between the second line and the third line medications. So, second line, the benzodiazepines. If you've heard of Valium, what did we call that in the 60s? Mama's Little Helper? Remember hearing that? And many people had used Valium. Whether it was for sleep or whether it was for nervousness or anxiety, it's a very good sleep agent. It makes us feel restful and it does put us off to sleep. But it starts to lose its effectiveness as a sleep agent in about 2 weeks. So people will find the first week of being on something like lorazepam, diazepam, any of the azopams, you'll see examples down there, it works really well for the first 1 to 2 weeks. And after 2 weeks, we start to develop tolerance, where your body may say, it doesn't work like it used to. And so your doctor might try bumping you up to a higher dose. But then after a while, that dose doesn't work like it used to, and the doses can get higher and higher. It is a controlled substance, so if your doctor prescribes it for you, they're going to have to print it out, put a little gold sticker on it, and send that to the pharmacy where you have to hand carry it. You can't have it electronically sent because it's controlled. And it does have many side effects. But for those that, let's say a life experience has occurred, and because of, again, the death of a spouse, that you have a few nights in a row where you're very challenged at getting to sleep. Is a medication like this potentially helpful? Absolutely. But again, it loses that loses that ability to give you good quality sleep, and you start to get more dependent on it after a couple of weeks. And the unfortunate side of this as well is that it is a dependency forming or habit forming. And many doctors will say, no, you can't get dependent on Valium. Yeah, you can. And if you have been taking it for a long period of time, the only way to start to withdraw off of it is very slowly. You should never, never, never cold turkey stop these medications if you've been on them for a couple of years onwards. If it's only been a couple of months, it's okay with stopping them cold turkey. But if you've been on them for years, never stop them cold turkey. There's actually bad outcomes that can happen with it, so you want to talk with your doctor about that. Again, the pros for the benzodiazepines, they work, they're inexpensive, but the cons as well, the tolerance, the longer half-life with some of them, flurazepam for example, the flurazepam gets broken down into another metabolite that is also active, and it stays in your body for a long period of time. I talked about the dependence, And then the one thing that we should all be aware of is if you're taking this and you're over the age of 65, the risks of having a fall while taking this medication are higher than the risks of somebody that's 30 years old and taking this medication. And what unfortunately happens if we have a bad fall? We're at risk of fracturing a hip. What happens if we're at risk of fracturing a hip? A lot of the studies have shown we have a lot of other health conditions and problems that occur if we break that hip in the first place. And actually our lifespan is significantly decreased by that hip fracture. So we want to prevent as many hip fractures as possible. And by preventing hip fractures, we have to look at preventing falls. At the back, we had handouts about what things we can do in our environments, our home environments, about fall risks. But also, one of the other risks as we get older and we take these medications is we can have some delirium. Delirium means you're seeing or visualizing or experiencing things that are not there. You're not cognitively aware of your environment. So people could start to have hallucinations while they're taking this medication. And the one really important thing to recognize is while it makes us feel more relaxed, it relaxes our respiratory center of the brain. And our brain sometimes will forget to keep breathing. And so people that are taking an opioid pain medication like oxycodone, hydrocodone, Vicodin, Percocet, fentanyl patches that you're on, if you're taking that along with a benzodiazepine, your risk of forgetting to breathe while you're sleeping is greatly increased. And this is how people are unfortunately dying right now in the United States. You're not dying from having too much medication, you're dying because the too much medication in your body is making your brain forget to breathe. And then people go to sleep and they just don't wake up. So, question?
You're saying that with a hip fracture, it can cause you to die sooner.
Mm-hmm.
How much sooner?
I wish I could get some better data in terms of months or years, but the lifespan of a person, I think you have a 3-year window where you're more at risk of having complications because of the hip fracture. Whether it's infection, not being as mobile as you once were. There's also some conditions where you can have the hip fracture first, and then you either have a blood clot or a fat clot from the hip area that goes up to the brain or the heart, causing a heart attack or a stroke. And those conditions are linked with having that hip fracture. So we want to try to prevent that hip fracture in the first place. Hip replacements are not shown to cause a decrease in lifespan. It's the fractures themselves because of the mobility issues. Hypnotics. These are also used for short-term use. Initially, when the FDA approved them, they were there for about less than 2 weeks of duration. But now some newer studies are showing that, well, maybe we can get by with using them for 6 months before tolerance starts to develop in the body, meaning you need more of the medication to give you the same sleep quality that you once had. But there are some side effects, and we say they're complex sleep behaviors. If you heard on the news or had friends or somebody that you heard the story where they were on a medication like this and they don't remember driving through Burger King drive-thru and ordering food and eating it, or people that have been walking around in their house and don't remember any of it, or having conversations where you pick up the phone and start having a conversation with somebody and then you wake up in the morning and you can't recall any of it. Those are the behaviors we're talking about with this class of medications. It's your Ambien, Lunesta, Sonata. These are the medications you see a lot on the TV ads now, where you don't really see a lot of the TV ads for the benzodiazepines. Number one, because the benzodiazepines are cheap. These ones are much more expensive. And the pharmaceutical agencies, they only advertise the things that are expensive. They don't advertise things that are cheap. So the pros, again, they do work. And maybe there's less tolerance that there is like to the benzodiazepines. That's why you could use them up to 6 months. They have a short half-life, and that's really important. By meaning a short half-life, it means that half of the medication is out of your body in a certain amount of time. And we don't want medications that have long half-lives because that means you'd wake up in the morning and you'd still feel a lot of the groggy effects of the sleep medication. It's also, some of them are available in generic. But again, the potential sleep behavior changes are the con, also metabolized differently in women. And again, having that high risk of falls. Anything that's going to make us drowsy at nighttime, and what do we need to to do in the nighttime again? Maybe need to get up to go to the bathroom, go pee. We're more at risk of having that fall if we're too drowsy and sedated at nighttime. So that's where some of the cons come in. Question?
What is metabolized differently in women?
So the question was, what does metabolize differently in women mean? It means that the half-life that I was talking about, it's a little longer in women versus men for some reason with this medication. So there's more of the medication that stays in your body for a longer period of time. Thank you for that question. And then we have other prescription medications we use for insomnia. Doxepin is an older tricyclic medication, but it does have some side effects. It can interact with medications. And Rameltion, or Rozarem, if we've heard of melatonin, I'm going to describe that a little later in one of the slides, but it actually works on the receptor that melatonin works on to try to improve sleep. And then a newer medication called Belsomra, and it works on orexin, which is a receptor in the brain, and orexin is a chemical that starts to wake us up when we're ready to wake up. And how this medication works, it blocks that orexin from working. So instead of starting to wake you up at a timely period, it makes you stay asleep for a period of time. And that's how that one works. It's not as well used as the other medications. But some of the pros, they're not controlled substances, so you can electronically send them. You don't have to have the prescription printed out. There's no dependence or tolerance with these medications. But the cons, they're expensive. We sort of question, are they as effective as the other medications? And then anticholinergic side effects with the tricyclic medications. And anticholinergics, you can have dry mouth, dry eyes. You feel the urge to go and use the bathroom, go pee, but your bladder is just not cooperating. It's not allowing it to release. Those are anticholinergic side effects. Blurry vision, dry mouth, dry eyes, and inability to void. Those are the main anticholinergic side effects. Question?
I wanted to just go back to the Ambien zolpidem
Yep.
for a moment. I seem to have a reverse metabolism, so that a lot of other things that would be easier to take, even NyQuil, I'm wired and, I can't take anything like that. The Ambien, I've discovered that I can take like a quarter or a third of that pill, and it does the trick. And but what I try to do is use it only if I'm having a problem the night before I'm leaving a trip or something where I need to be in good shape the next day, so I'm not falling, carrying luggage and stuff like that. But,
Right.
Yes, if you take it more than 2 or 3 nights, you have to go off slowly, and it's hard to. You have one night of not much sleep.
Right.
So it's a mix.
And the take-home message there for people that may not have heard all of that was as low an amount as possible. Sarah was talking about that she can take 1/3 of the dose of the medication and have a very good sleep with that 1/3. So always see what lowest amount of medication is still effective for you without those side effects. She also mentioned NyQuil. I'm going to be going to one of those slides soon. But things we traditionally have used over the counter can actually have the adverse effect on us. We think we're taking it to make us feel drowsy, but in fact we feel wired. And that happens more as we age too, so I'm glad that you brought that up about the NyQuil. We're at this one here. So, other medications that are not FDA approved for insomnia, but we often have used, chloral hydrate. This is still used in the hospitals at times. And I remember prescribing this if people had problems falling asleep. It's not FDA approved for sleep, but for some reason it can give kind of a sedative effect to people. And then some of the other antidepressants, antipsychotics we've used for sleep as well, even though they're not food and drug regulated. But the ones that are, these are all higher risk in the elderly, except for trazodone and the mirtazapine. So some of you still may be on a medication, trazodone. You can get some of the anticholinergic side effects that I was talking about, but it's not a dependent state, and we don't have the high risks in terms of falls from the trazodone. Antihistamines, some of our favorites, Benadryl, excuse me, Unisom, and then NyQuil. NyQuil has amounts of Benadryl, the active ingredient of Benadryl in it. And we use that for cough, cold symptoms, but many people have tried using it for nighttime sleep, and actually gives a short-term treatment, or short-term effect only, but can give this paradoxical reaction in the elderly, where instead of making you feel tired, you're feeling very wired, and agitated, actually. And so we use a lot of caution with this medication. We don't actually recommend it in people that are 65 and older. Not that anything magically happens when you're 64 years and 364 days, and then you all of a sudden have your 65th birthday. But in the studies that have been done, Medicare uses that age 65 and older to do their studies. And that's why we say 65 and older, use caution. Question?
My experience is antihistamines exacerbate the restless leg syndrome.
That's been my experience too. I'm so glad you brought that up. Her comment was, her experience was that antihistamines exacerbate or make worse restless leg syndrome. I've seen that myself too, where I've had sometimes a hard time sleeping, and because of my restless leg syndrome, and I go and take a cough and cold medication, Benadryl, and it actually made it worse for me. And the hangover effect in the next morning, I found I didn't like the way Benadryl made me feel the next morning. I felt very groggy waking up. And so the best thing is restless leg syndrome. If you're having that and your legs are twitching and kicking, get up and walk around for a bit and use the legs, and then go back to sleep. So there's some herbal drugs as well that people have used for insomnia. And the only thing we have to recognize with herbal is that the quality insurance. So if you take a Benadryl and it's an over-the-counter medication, you know that 50 milligrams of Benadryl or 25 milligrams of Benadryl is the exact same in every single tablet. When it comes to herbal things, there is no standardization of the quality. So you might take something that has a little more in one tablet or a little less in another tablet, all in the same bottle. And the statements have not been verified by the Food and Drug Administration. So it's what you always have to remember about anything that's called herbal. Other people also think that, well, if it's herbal, it's natural, and natural won't hurt me. Aspirin actually came from bark, which is kind of something natural. But if you take too much aspirin, what can happen? You can actually start to have kidney problems, you can actually start to have ear problems, hearing problems. We can have toxicity with something that's natural. So just because something's herbal doesn't mean it's safe. There are side effects with almost anything. But these are some of the herbal things that some people have tried. Something called kava. It's a plant root that was used as a drink in the Pacific Islands. It's not recommended for insomnia, though, due to liver toxicity. So you have to be aware that it could irritate, inflame the liver. So if you're a person that has a couple drinks of wine every single night, and then you're having problems with sleeping, it's probably not a good idea to take kava, because those two things together can irritate the liver even more. Valerian root. It's a root of a flowering plant, and there's been some thoughts that maybe it helps make us relaxed a little bit more. People have used this for anxiety over the years. But again, there's the potential for liver toxicity and also withdrawal symptoms if you use it for a long period of time and then you stop it abruptly. Some people have noticed their anxiety symptoms actually get worse. But you'll hear that it's out there. Now, melatonin. Well, what's up with melatonin? It's a hormone that's made by the gland in the brain. The pineal gland is right by the hypothalamus and the pituitary. And this, it affects how much the body produces dependent on the amount of light that we're getting in. So remember, in the first discussion that we had, I was talking about how much light the retina is getting, and the retina is sending the pathway right to the hypothalamus. Well, this affects how much melatonin that the pineal gland also produces. And melatonin is good for us. Melatonin is what gets us into those different stages of sleep. But we know the levels drop slowly as we drop with age, just like the levels of almost anything drop as we get older. But this is why one of the issues with sleep problems start to develop as we get older. It's an issue with melatonin. So there's a lack of evidence, though, for the treatment of insomnia with melatonin. What do I mean by this? It doesn't mean there's no evidence. It doesn't mean there's no help you can get from it. There's just a lack of the evidence. Now, why is there a lack of evidence? Well, melatonin is really cheap and it's inexpensive. And no pharmaceutical company that I know is going to go and do a study on something that's cheap. They are only going to go and do a study on something that can make them money. So this is why we don't have good evidence for it. It doesn't mean that it won't help you. It's just that I can't tell you that there's a study out there that a pharmaceutical company has done that says it's helpful for you. Question?
Yes, what about using melatonin with children?
Yeah, the question was, what about using melatonin with children? And in the studies that I've seen, for children that have sleeping issues, that it may be effective. And it doesn't work the same as a sleeping pill. It's not a sleeping pill. And you have to take it quite a bit, like several hours before bedtime. It's not like you take it and then 5-10 minutes afterwards you're feeling drowsy. The recommendations are, if you're going to try melatonin, use it at least 1 to 2 hours before you want to try to fall asleep. And the dose will range widely from everybody, all the way from 0.2 milligrams. So in children's studies, I've seen that kids have used anywhere from 0.2 milligrams to 2 milligrams, and it's been helpful in some kids. As adults, you may have to take it all the way up to a 20 milligram dose. And they don't feel that this is additive or dependent over time, and it doesn't accumulate in your body. But just like anything else, it may lose effectiveness after 6 months to a year, where you need to kind of take a melatonin break, and then maybe you could try it again. But of all the herbal things that are out there or over-the-counter additives, this is probably one of the quote-unquote safest that you could try. Sleep hygiene, again, though, is number one. And that's our behavioral interventions that we can do to promote a better quality of sleep. And it can be used in combination with the other therapies that I talked about. And the most wonderful thing about this is there's no side effects. So with that, we've had some questions throughout. I wanted to turn it over to my friend Patty Hopkins. Has Patty Sheffield on the agenda, but Patty recently got married a couple of weeks ago, and so she is going by her new name, Patty Hopkins, and she is one of the health coaches that is within SamFit. I've known Patty for many years, and she is a wonderful human being first and foremost. But her second thing that she is so great at connecting with people in terms of getting them to their wellness activities for their own benefit. She has headed up a lot of the wellness activities in teams and cohorts throughout Samaritan Health Services, and everybody from the coast all the way to Lebanon and Sweet Home that interacts with Patty just loves her. So Patty is here to walk us through some thoughts on meditation. We're going to take a couple of minutes here to transition the microphones so that the videotape can still get everything that Patty is saying. And so while we're doing that, I'm happy to project and answer some questions while we're helping Patty get set up.